Hi everyone, I'm just going to record my presentation, so stay with me please. So hello everyone, my name is Jonas Ludvigsson and I'm going to give this talk leveraging clinical databases for pharmacoepidemiology and quality measures. I'm a pediatrician and an epidemiologist from Sweden, from the Karolinska Institutet and Örebro University Hospital. I'm very happy to be here at the DDW 2021. So I imagine the reason for being given the opportunity to give this talk is this paper in the New England Journal of Medicine under the leadership of Tracy Simon, hepatologist at MGH, where we looked at aspirin use and the risk of liver cancer and hepatitis B and C, and I will come back to that paper. I want to mention I have some experience in pharmacoepidemiology. For instance, these three papers in the BMJ, one about antibiotics exposure in early life and risk of childhood asthma. Another one which touches upon the fact that pharmacoepidemiology is not only about drugs, but also vaccination, is this paper about maternal vaccination against H1N1 flu and offspring mortality. We just recently also looked at autism risk in the offspring. And here, an indirect measure of pharmacoepidemiology, which is glycemic control, reflecting insulin use in women with type 1 diabetes and risk of major birth defects, published a few years ago. I have some disclosures. I have some funding for an unrelated IBD study by Janssen, and I've also written a book describing the deaths and disease in the Harry Potter books. You can buy this one on Amazon.com, and I will earn 10 cents for every copy you buy. Now, getting serious, the first time I thought of pharmacoepidemiology was when this paper was published in '94 in the New England Journal of Medicine. And as you can see, it was published by someone called J. Ludvigsson, Johnny. That is actually my father. I mentioned this paper because it was an inspiration, source of inspiration, but also because this explains why I use my middle initial. So to the left, you have Johnny Ludvigsson, JL, then you have someone else in the middle, and then you have me to the right. I'm JFL, Jonas F. Ludvigsson, and that is to separate me from my father, to distinguish me from my father. So for the next 27 minutes, I'll guide you through pharmacoepidemiology from a database perspective. I'll talk about the personal identity number, which is the key linkage between registers. I'll talk about different registers, especially the prescribed drug register, and I'll also talk about aspects of pharmacoepidemiology. So first of all, the personal identity number. This is a unique identifier assigned to all Swedish inhabitants, and it enables us to link large databases. Everyone in Sweden with a personal identity number can also be found in this register of the Swedish total population. And if you're interested, you can read more in this paper. The total population register allows us to calculate total population, to link, to find out who is in Sweden, who has emigrated, who has immigrated, but also to look at the size of different population groups, which is indeed important when you want to calculate incidence and incidence rates. As part of the total population register, there is one part where we link first-degree relatives. For instance, in the total population register, you will find a person's mother, father, siblings, and offspring. And that part is called the multi-generation register and can be used to ascertain both drug use, but also heredity for various diseases. One example here is a paper by my collaborator Mingyang Song at Harvard, a paper soon to be published in the BMJ, where we retrieved data on polyps in first-degree relatives and looked at the risk of colorectal cancer. The Swedish registers, well, in fact, the Nordic healthcare registers cover the time period from the cradle to the grave. They carry the birth period and fetal life in terms of, through the medical birth register. We have the patient register, we have the cancer register, we have the cause of death register, we have various registers. I want to touch on three important aspects for databases to be useful, registers to be useful for pharmacoepidemiology research. One is that the register needs to have sufficient follow-up and no loss of follow-up. If we take the patient register in Sweden, it was started in 1964, became nationwide in 1987. That means we have a large amount of follow-up in this register to follow up on the effects of drug use and other exposures. And we have no loss of follow-up. You cannot opt out from the national healthcare registers in Sweden, which means we have the rich and we have the poor. We have everyone. You also need a high coverage. And in Sweden, we have a comprehensive universal access to healthcare. Everyone is in it, whether you're rich or you're poor. And we will be able to identify everyone with, for instance, myocardial infarction diagnosed in healthcare, or everyone with inflammatory bowel disease diagnosed in healthcare. You can simply not, change insurer or claims database and then get lost. There's just one database to keep track of us all. And then you need a high quality. And most of the healthcare registers in Sweden have a high positive predictive value. For instance, in the patient register, it seems that for most diagnoses, we have an 85 to 95% positive predictive value. That means if you have the diagnosis, it's about 90% likely that you really have the actual diagnosis. Still, we sometimes find incorrect diagnosis. Let's assume that we have a record of 50,000 patients who should have had K50, the International Classification of Disease Codes for Crohn's disease. A few of these will just by mistake have been assigned C50, which is breast cancer. If you have a patient with, say, 5 ischemic heart disease diagnosis, I20, and then the same person has 1 L50, and then followed by another 3 ischemic heart disease diagnosis, the L50 could be an incorrectly coded I20 replaced by L20, which represents eczema. It's also possible that some physicians have assigned investigated for IBD or suspected to have IBD, and the secretary has entered the code for IBD. And that is not equal to having the diagnosis. It's more a patient having a workup for diagnosis. If that patient just has one UC diagnosis, but then followed by a GI infection, and then never more UC diagnosis, that was probably an incorrect UC diagnosis. And then, of course, you have patients who actually switch diagnosis. So the first CD diagnosis may turn out to have represented UC. So what can we do to increase the specificity of diagnosis in the registers? Well, here's one approach that I used together with my former PhD student, Ola Åhlén, in a paper in The Lancet last year about colorectal cancer and ulcerative colitis. We required every patient with IBD to have at least 2 diagnoses, and that pushed up the positive predictive value so that the PPV was 93%. We then also, of course, had to start the follow-up at the second of these IBD records so as not to introduce immortal time bias. What's interesting also with this paper is that it illustrates the very long follow-up that we see in many healthcare registers in Nordic countries. This paper had 48 years of follow-up, of course, offering tremendous statistical power. Other ways to increase the specificity is to use only main diagnoses, which are usually more valid than secondary diagnosis, or to use only diagnoses recorded in certain clinics. For instance, only to accept GI diagnosis from the medicine department, surgery department, pediatric department, or GI department, and not GI diagnosis only assigned to a patient in the dermatology department, rheumatology department, or neurology department, where physicians generally do not work with GI diseases. We can also combine a patient register record with a certain drug. For instance, type 1 diabetes patients usually have insulin. If they do not have a record of insulin, you have to question the diagnosis type 1 diabetes. And you can combine data from different registers to increase the specificity. For instance, let's say you have an ICD code for IBD, and then you have a biopsy consistent with IBD. Of course, that increases the specificity of the diagnosis. This is what data can look like from a national healthcare register. In the left-hand column, you have the LPNR, the loop number. That is a serial number that replaces the personal identity number to safeguard the integrity of the patient. And then you have data on hospital, data on sex, data on age, data on date of hospital admission, etc., etc. You can also combine national healthcare registers with registers of your own. And here is one register or a cohort study that I'm in charge of called the Espresso cohort study, where we have data on all GI biopsy reports in Sweden. We have data on 2.1 million unique individuals undergoing biopsy from the GI tract, including the liver, gallbladder, and the pancreas. And in total, they have 6.1 million biopsy reports. We can combine that with, for instance, the patient register, the cancer register, the cause of death register to do some good research. So to summarize, the national healthcare registers in Sweden, as well as in the other Nordic countries, they're cost effective, they're population-based, they're non-selected, meaning we have all public healthcare, both poor and rich people, and you simply cannot opt out from these registers. Data are not influenced by one's hypothesis because they were collected as part of routine healthcare. And the data delivered to you as a researcher are generally anonymized to safeguard the integrity of the patient. Some of these data have already undergone data quality review before they're delivered to researchers. Other data you need to look at yourself. So you cannot opt out as a patient. This means complete coverage, no loss of follow-up. So we have the complete population. Now over to perhaps the most important register for this talk, and that is the prescribed drug register, which started in 2005. The content of this register is that we have data on dispensed items, data on amount, dosage, although sometimes you have to apply text mining to find out about the dosages. We have place of residence, we have data of prescription and of dispensing. We also have the profession of prescriber, but we do not have indication for the prescription. Neither do we have data on over-the-counter drugs or drugs given in hospital. We have some of these drugs, but much of it we do not have. So while this register is limited to prescribed drugs, it should be understood that we have the complete population and we have all prescriptions. So we have 100% sensitivity for prescriptions. And we also have drugs from primary care, even though primary care otherwise is not part of the patient register. The patient register is based on diagnosis from hospital, inpatients and outpatients. But the prescribed drug register includes drugs also from the primary care. Still, there can be problems with drug data even in a complete register. For instance, when you study prescriptions, you have to keep in mind that an association with between a drug and an outcome may not be due to the medication itself, but could be due to underlying disease activity. I think this happened to us in a recent paper in the Journal of the American Society of Nephrology, where we looked at mortality in IgA nephropathy, me and my PhD student, Simon Jarek. We noted that patients with IgA nephropathy and steroids or immunosuppressants or certain antihypertensives were at increased risk of death. We have to ask ourselves, is that due to the medication or is it actually due to the underlying disease activity requiring a certain medication? In this case, I think it's due to the underlying disease activity, and that explains the increased mortality. We also have to acknowledge that some patients have a prescription, they get their drug, and they don't take it, or that there may be a selection of patients who stop taking a medication, where those having severe side effects are more likely to stop taking the medication than those not having side effects. And then, of course, some medications are unfortunately not recorded. Over-the-counter medications have been mentioned, but also, for instance, those you receive from a relative or a neighbor. For instance, you see a neighbor, you have problems with your stomach. You tell your neighbor and he says, well, why don't you try one of my pills? They feel great, and you try them. Those medications do not enter the prescribed drug register. There's no way to find out about them. I want to add this talk, we're discussing 3 specific studies in GI. We will discuss TNF-alpha inhibitors and risk of serious infections in pediatric IBD. We'll discuss aspirin use and liver cancer in patients with hepatitis B and C. And we'll talk about antibiotics and risk of IBD. I want to acknowledge my collaborators here, Vincent and Pasternak at the Karolinska Institutet, Tracy Simon at MGH in Harvard, Long and Nguyen at MGH and Harvard. So first of all, a Danish study, and that may come as a surprise, but as I mentioned, these healthcare registers are also available in Norway, Denmark, Finland, as well as in Sweden. So I'm taking a Danish example. This is about TNF-alpha inhibitor and in children with inflammatory bowel disease and the risk of serious infection. It's a paper published in the Lancet Gastroenterology and Hepatology in 2019 by Victor Vincel and colleagues. And the background for this study is that there had been reports that in adults with IBD, TNF-alpha inhibitors were linked to serious infections, but data in children were very scarce. So the first thing I do in a pharmacoepidemiology study is identifying the study population. In this particular study, we were interested in IBD patients and IBD patients only because we were going to compare those patients with TNF-alpha with those without TNF-alpha inhibitors. We looked within the patient group. And we wanted to make sure that these patients really had IBD and really had active IBD. So we required 2 IBD diagnoses and said at least 1 diagnosis was needed in the last 3 years before study follow-up. The next thing to do is to, so to say, clean the study cohort and refine it to have the kind of study cohort you really think is representative of the average IBD patient. So we excluded patients for administrative reasons, for instance, patients who had lived outside Denmark in the last 5 years and who we might not be able to keep track of. We excluded patients who had inactive IBD, as I just mentioned. We excluded patients with a very high risk of infection, such as patients who had an early transplant, a known immunodeficiency, or someone who had a recent infection within the last 30 days. We also excluded patients with chronic infections because with a chronic infection, it's very hard to say that a new record represents new disease rather than just old disease. We excluded patients with cancer because they might have specific reasons to avoid TNF-alpha inhibitors or to have an increased risk of infections. So after these exclusions, there remain typically average IBD patients, children. We then made a number of assumptions concerning the use of TNF-alpha inhibitors. We assumed that guidelines in Sweden with certain intervals between dosages would have been followed. We decided that we would accept a gap between 2 prescriptions of up until 60 days and still regard the patient as being on continued use on TNF-alpha inhibitor. We wanted new TNF-alpha inhibitor users, so we excluded patients with an earlier record of TNF-alpha in the last year. And then finally, I want to say that one individual could contribute several episodes. We actually decided to look at episodes with and without TNF-alpha inhibitor, with one patient could contribute 1 episode of 3 years without TNF-alpha inhibitor, but then another episode with TNF-alpha inhibitors. The next step is to define the outcome and to make sure it is really serious infection. We invested a lot of work in getting the ICD, International Classification of Disease codes, right, to really catch all serious infections. But we also decided to limit ourselves to infection code assigned to inpatients in the hospital, those having a hospital admission, because only then could we be sure that these were serious infections and infections not just picked up because IBD patients are more likely to see a physician on their regular visits to the outpatient clinic. So serious infections. But the trickiest thing, however, in this study was to make sure that the only thing that differed between patients with TNF-alpha inhibitors and those without was the medication. Because making table 1, we could see that patients with TNF-alpha inhibitors, as opposed to non-users, had higher healthcare use, longer disease duration, they'd had more antibiotics, more often anemia drugs, more oral and local steroids, and more thiopurines. So how could we tackle this? Well, what we did was we assigned a kind of propensity score model where we tried to balance the groups with users, non-users. And we took a large number of variables into account into this model, here marked by the red line to illustrate some of them. Within the green line, in the green box, you can see that there were differences between those on and off TNF-alpha inhibitors, the first 2 columns to the left. And then after balancing the groups, you can see that the percent difference, that is the far right-hand column, is very small, comparing those with and without TNF-alpha inhibitors. So in the main analysis here, you see, I want to stress a few things. The first is to compare the blue and the right line. And after 3 years of follow-up, you can see that among those with TNF-alpha inhibitor, about 12% had a record of serious infections, while those without TNF-alpha inhibitor had 14% of them had a record of serious infection. No big difference, a hazard ratio of 0.81. That, however, may be difficult for the patient and for the physician actually to understand. So I think we should look at the y-axis here at 1 year. And what it tells us here is roughly this. In 100 children with IBD with TNF-alpha inhibitors, during the first year, there would be 5 infections. In 100 children with IBD without TNF-alpha inhibitors for 1 year, there would be 6 infections. And that is roughly 0.81. But is the main analysis enough? Well, no, it's not. We also need to check subgroups, and we need to check sensitivity analysis. So here we looked at age groups. We looked at males, females to see the association between TNF-alpha inhibitors and serious infections. We looked at various calendar periods. We also identified clinically relevant groups, such as those with recent steroid use. What was the association between TNF-alpha inhibitors and serious infections in that particular group? What was the association in those with recent therapurins? What was the association in those undergoing surgery, etc.? And we also changed some of our study assumptions. We changed the intervals of drug. We changed the gap. We changed the inclusion criteria somewhat, saying, what if we exclude those with very early onset IBD? Does that impact on the hazard ratio 0.81? No, it does not. Over to study number 2, which I carried out together with some collaborators at Karolinska, Örebro University, and Harvard MGH, with lead investigator Tracy Simon, aspirin use in hepatitis and risk of HCC or liver-related mortality. And first of all, we defined the study population. Here we went for the quality register of hepatitis B and C, where data on hepatitis B and C are entered by dedicated physicians working with hepatitis B and C very often on a daily basis. So we expected a very high validity for this patient group. And we then took out individuals who had an earlier record of HIV, HCC, which we were going to study. We were going to study future HCC, so we could not accept those who already had HCC. We also excluded individuals with an existing prescription for aspirin or other antiplatelet drugs. And then finally, we applied an entry period of 180 days, which should be free of aspirin, to make sure that the next record of aspirin would signal a new user. As you can see here, if you compare those on aspirin with those without aspirin, the 2 middle columns, there are differences in the proportion with, say, hypertension and obesity. And we therefore also in this study applied a weighting method to balance the 2 groups, and that the difference between the 2 groups after this weighting is shown in the right column, the far right column. And here you can see the cumulative incidence of HCC. The 2 graphs here show exactly the same thing, but with different y-axis to increase visibility. But I also want to stress the content within the green box here, the green line, and that is the difference in percentage between those with and without aspirin. So after about 10 years of follow-up on aspirin users have a 4% lower risk of HCC, and that is in absolute terms. So a 2% risk roughly in that group compared to, say, 6% in the group without aspirin, roughly. Well, we also carried out a large number of sensitivity analysis to test the robustness of our model. We looked at individuals who continue with aspirin for more than 1 year, and they had a lower risk of HCC than those who stopped aspirin within 1 year. We looked at discontinuation of aspirin. What about if you stopped aspirin? If you stopped aspirin, your risk of HCC started to increase again. And the longer the discontinuation was, so to say, the higher the risk of HCC. We also looked at the individuals who had a record of high adherence, that is, had prescriptions that covered a large proportion of the time. And those having a high adherence had lower HCC risk. We looked at competing drugs, censoring for initiation of other antiplatelet drugs. No effect. We excluded individuals with earlier alcohol use. No effect. We started a follow-up at 4 years that did decrease the inverse association with HCC somewhat, but there was still an inverse association, a likely protective effect. We also looked at alternative endpoints saying, okay, now we've looked at the risk of HCC and the risk of liver-related death. What about if we look at decompensated liver disease? We still saw an inverse relationship with aspirin. And then we asked ourselves, okay, could it be that aspirin would be associated with a reduced risk of any kind of disease? This is not liver specific or cancer specific. We then looked at the risk of future diabetes, which was not linked to aspirin use. And finally, we also calculated the risk of unobserved confounding. So we did a large number of sensitivity analyses to confirm the robustness of our findings. However, whether you prescribe a drug or not, I think it's due to the efficiency or the effect of the drug, but it's also, we should also consider the side effects. And for aspirin, that could be GI bleeding. And we therefore carried out an analysis. Our aspirin users had increased risk of GI bleeding, and the difference against those without aspirin was not statistically significant. Here's the final study I'm going to talk about, a paper in the Lancet Gastroenterology and Hepatology from last year by lead author Long Nguyen and some collaborators at Harvard MGH. This is a fairly straightforward case control study where we compared IBD patients with controls. And our question was, is earlier antibiotics a risk factor for IBD? And I want to stress two aspects in this study. One is that we worked a lot with when does the disease IBD start, and up until what point in time before the diagnosis should we consider the antibiotics? Because what if an antibiotic was prescribed due to symptoms from undiagnosed IBD, which can precede IBD diagnosis? Say, for instance, that you had IBD and it was misclassified initially as a GI infection, and you treated it with antibiotics. What if you had perianal disease, which was treated by antibiotics, and only later you received a diagnosis, or at least only later a diagnosis was recorded? I think to keep some kind of lag period between the start of the disease and at the time point up until when you consider medication as an exposure is extremely important, especially for drugs which are commonly used as treatment in GI disease. And that is something we discussed a lot when we looked at use of proton pump inhibitors and risk of celiac disease, where, of course, PPIs can be used in some patients to treat diffuse abdominal symptoms that might turn out to be celiac disease. So in the study by Long and Nguyen, we applied a lead-in period of 1 year. And then we also, in a sensitivity analysis, tested what about if we had a 2-year lag period between up until which we calculated antibiotics and then 2 years up until first IBD record. We also looked at whether increasing amount or the number of dispensations was linked to future IBD. And here we could show that the more dispensations with antibiotics you had, the higher the risk that you would develop UC or Crohn's disease. And you can either count prescriptions or you can count prescribed days or cumulative DDDs. We also looked specifically at narrow spectrum antibiotics versus broad spectrum antibiotics, finding the broad spectrum antibiotics had a stronger link to future IBD than narrow spectrum antibiotics. So to summarize, pharmacoepidemiological studies improve the lives of patients. Large databases are becoming more and more important in research on GI medications, and methodological challenges are found in pharmacoepi, but also great opportunities. And with that, I'd like to thank you all. Thank the DDW organizers for the conference and the opportunity to talk, my collaborators, and those helping me out with the presentation. Björn Pasternak, Henrik Svanström, Victor Wilson. Thank you very much.